Hi, this is Laurent Duvernay-Tardif, or best known as Laurent Duvernay-Tardif, or just Larry. I'm a guard for the Kansas City Chiefs, as well as a graduate of medicine. I want to wish you guys the best virtual NATA Symposium. Thank you so much for all the work you're doing to keep us safe so we can play the sport that we love. Enjoy the symposium, guys.
Hello, this is Chris Hall from District 6. I just want to say thank you for supporting NATA this year. Thank you for all the things that you do in your communities as an athletic trainer, representing us on the healthcare consortium. Stay after it, protect each other, protect yourself and your family.
Welcome, everyone. In order to earn your CEUs, you must watch this session in its entirety, and then take the assessment by clicking the assessment button above the session window. During the live VNATA event, presenters will be standing by in the chat box to answer your questions. You can also use this feature to chat with other attendees. During the on-demand portion of VNATA, the chat feature will not be available. Thank you for being here at VNATA. Enjoy the session.
Hi, everyone. My name is LaGwen Durden, and I am the Director of Sports Medicine within the Sports Science Institute. I'd like to welcome you to our panel discussion on COVID-19, where we will focus on challenges associated with the re-socialization of sports during this global pandemic. Our goal is to address various health and safety considerations that healthcare providers may have as they prepare for student athletes' return to campus. We hope that this information may prove helpful for team physicians, athletic trainers, mental health providers, athletic healthcare administrators, and any other individuals responsible for the healthcare delivery on our college campuses. First, I'd like to introduce the panel members joining me in this discussion. Dr. Stephanie Coakley, a mental health care provider at Temple University, where she is the Senior Associate AD for Mental Health, Wellness, and Performance. Ron Corson, an athletic trainer at the University of Georgia, where Ron serves as the Senior Associate Athletic Director for Sports Medicine and also the Athletics Healthcare Administrator. We also have John Dunham, an athletic trainer at Emory University, where he serves as the Head Athletic Trainer and the Athletics Healthcare Administrator. And Dr. Brian Hainline, the physician, Senior Vice President, and first Chief Medical Officer of the NCAA. To begin our discussion, I'd like to ask each of you to describe your role and function during this COVID-19 pandemic. Dr. Hainline, I will start with you. The National Office has established several decision-making groups to guide our response to this coronavirus outbreak. One of those being the COVID-19 Advisory Panel, and a second being the COVID-19 Action Team. Brian, if you would, speak to your involvement with these groups and the function of both groups.
Well, thanks, LaGwen, and welcome, everyone. It's really a pleasure to be with you. So these groups, and I'll maybe mention a couple of others as well. So the NCAA COVID Advisory Group, that's a group of 7 external experts in global health, public health, infectious disease. One of the members actually is an expert in security at mass sporting events. And the other is a member of the Committee on Competitive Safeguards and a team physician, Stephanie Chu. So the 7 of us, we meet at least twice a week. We communicate almost daily. And they really have provided a guidance perspective that really is looking at COVID-19 from a regional and national point of view, and even from a world point of view. And that's really helped considerably to shape our policies and our educational efforts. Then we have an internal team, we call it the COVID Action Team. That's essentially the senior management of the NCAA, so the senior and executive vice presidents. And it doesn't include Donald Remy or Mark Emmert, our chief legal officer and president. We actually report to him. And it includes our general counsel, Scott Beerby. We've been meeting essentially daily, sometimes twice a day. And the focus has been twofold. One is, what about the national office and our policies and how we really went to virtual meetings right away. But more importantly, we've been focusing on the championship. So we first had to really work through what are we going to do with the winter and spring championships. And we've been spending an enormous amount of time on how are we going to roll out summer activities and the fall season. And so that's been a regular engagement, and just a couple others. There's a working group with the American Medical Society for Sports Medicine. They've been invaluable. And then our own committee on competitive safeguards and medical aspects of sports. And then, of course, with our many other organizations ranging from NATA and the invaluable expertise we get from them, our licensed mental health providers. So, and then with the membership. So it's been a phenomenally collaborative effort.
Thanks, Brian. I'd like to turn now to Ron Corson. Ron, I know you've been very involved in discussions trying to determine how to manage the health and safety of the student athlete while they sheltered at home, and plans for their return, not only on your campus, but also with primary athletes healthcare providers in your surrounding area and at the broader conference and A5 level. Would you describe your role during this pandemic?
Yes. First, we wanted to keep our sports med service operational. We had 550 athletes, and we stopped immediately, and we had athletes scattered across the country. So trying to find some creative solutions, how to keep treatment protocols going, rehab protocols going, stay in touch with them on a regular basis, and not only stay in touch about their individual treatment needs, but also give them information about COVID. From a campus standpoint, we formed a return to sport committee, and we also formed a return to work committee. We established infection control policies and worked really closely with the university officials on that. And then from a conference standpoint, the SEC, we put together a task force to look at COVID return. And we put together 14 individuals across the conference. It was a really interesting group. It was multi-purpose athlete trainers, physicians of various specialties, team physicians, public health officers, infection control, and you really tried to work together to craft some protocols for everyone.
Great. Thanks, Ron. Dr. Coakley, as a certified mental performance consultant and licensed professional counselor, what has your role been as your campus worked through its decision-making process in the aftermath of this health crisis?
Hi, thanks. Good afternoon, everyone. My role has primarily been to coordinate the mental health services for our student athletes, and it's changed as we've moved and progressed through this period since March and the spring. So initially it was just helping our student athletes ground themselves in a way that they could still succeed as students, because sports was taken away from them, which was something that we worked with them to help them to process, I guess. So a lot of helping them to understand what their new normal would look like for the rest of the semester, establishing a routine, prioritizing sleep, maintaining healthy nutrition, maintaining connections, not only with their teammates and coaches, but their other members of the university community that were suddenly taken away from them. For student athletes who were in counseling services, we immediately transitioned to telehealth work. And that was a pretty seamless transition using the Zoom platform. We have a HIPAA-compliant Zoom platform that we've been using with our student athletes. So we've been able to maintain all of our services in a virtual space, to include our psychiatric clinic that we hold once a month. So all of those things proceeded as normal as possible through May. And what we normally do in the summer is to take time off, but because of the climate and the conditions, not only with COVID, but everything else, we've maintained all of our services throughout the summer. Some student athletes have retained their services and stayed on. Others have chosen to take a break until the fall. So the bulk of what I do is to coordinate the mental health services. But then there are student athletes who aren't involved in mental health services, and so that's where the wellness comes in. So constantly using social media, mass emails, just to communicate with our student athletes and check in with them, see what they need. And not just our student athletes, but our coaches, our athletic trainers, our other members of our staff, because we're all going through this crisis, and we are all at risk due to all the uncertainty. So while our student athletes are the priority, we are really wrapping ourselves around our athletic department staff.
Wonderful. Thank you for that. Finally, I'd like to turn to John Dunham. John, in addition to serving as the head athletic trainer and athletics healthcare administrator at Emory, you're also the D3 representative on the NATA Intercollegiate Council for Sports Medicine. Would you speak to the role of the council and the work you've done to address some of the issues healthcare providers are dealing with during this time?
Yeah, no, absolutely. We started back really early March and what it would look like and how we could assist our colleagues with the pandemic. We formed a pretty large working group and we put together the return to athletics recommendations. They came out, I believe, early May. In addition with that, working with the American College of Health Association, and really both our recommendations mirrored each other and really worked off each other from that standpoint. Then from there, it's really just been constant communication with colleagues and the questions and I think what we found with COVID is it's like an onion. The more you peel back and the more you talk about it, the more you don't know or the more things you got to think about. And it seems like the more conversations we've had, with all of our colleagues and everyone that's in, it's the more things we have to think about. The Division III, we put together a webinar in May. It was with the ICSM Division III, the commissioners through NACTA, the Division III Commissioners Association, the Division III Athletic Administrators Association through NACTA, and really presented the guidelines in conjunction with Mike Huey from the American College of Health presenting their guidelines. So I thought that was very, very beneficial for our membership. I think we had over 3,000 views on that, and still going. Also, the ICSM, we did 2 additional webinars that I think were very successful. And it's just, we put all this work into kind of what the recommendation is. Then I realized oh, now I got to go to work and actually do the recommendations. And that was the hard part. So.
Perfect. Thanks, everyone. I'd like to shift our discussion now to specific questions that we've heard from the sports medicine community. Brian, I'll start with you. The core principles of re-socialization of collegiate sports document was recently updated to include action plan considerations. If you would, please share your insight on how the re-socialization document came about and the purpose of the document, and also speak to the importance of the additional guidance.
Well, thanks, Gwen. So our first document, which was Core Principles of Re-socialization of Sport, when we were putting that together, we were in our probably 3rd or 4th draft, and that's right when the White House document came out called Opening Up America Again. And that document was a phenomenal document, the White House document. It really talked about syndromic surveillance and testing strategies, contact tracing, and had projections for phasing criteria. But what happened, and so we decided to really blend our document with that. But what happened over time is that the White House did make it clear that there would not be a national testing strategy, and the CDC is not overseeing contact tracing, and so syndromic surveillance is really not going where we had thought it originally was going to go. So, and it's been really a state-by-state rollout, which has had considerable variability. So when that was just starting to happen, we came out with our second document, the action plan considerations, and that's when we got a little more granular about looking at the risk of sports. So you can have a very low risk sports and for COVID transmission, and then you have higher risk sports like, let's say, basketball and football, a low risk sport being something like swimming. And so we talked about the importance of physical distancing, masking, and so forth, and started laying that out. But now we have the release of our third document, which is very, very granular. It's in updating risk considerations. So in this document, we start off by really showing a very painful graph. it's the graph states, look, this is when the NCAA started the re-socialization conversation. So this was back in April. And based on that, there was a projection of where we should be right now. And that was a continued downward projection in terms of new cases. And what happened just a week or so ago is now it's a marked upward trajectory. And in fact, there are several states in the United States that have higher infection rates, caseload rates than many countries in the world that are highly infectious. And so it's caused us to reconsider things. And so in this document, we say, well, what works and what doesn't? Well, the phasing criteria doesn't make much sense anymore. And even to say, well, to have groups of 10 or groups of 50, doesn't matter if you have a group of 10, if everyone's doing things poorly from the point of view of physical distancing and masking, everyone's going to get infected potentially. You can have a group of 500 where no one's going to get infected. So we really emphasize the only thing we know that works short of staying home. That's hand sanitizing, cough and sneeze etiquette, physical distancing, and universal masking. And we really focus on universal masking. That's unfortunately become politicized, and it shouldn't be. I'm in New York, and I can text and be on a phone all I want. That's my personal liberty, right? I can't drive a car and text, because if I do that, I have a much higher risk of killing someone else. That's a public health issue. And that's what wearing a mask is all about. We get into really great detail about asymptomatic carriers and even those who have when they're actively infected but they're asymptomatic. So we go from there and we get into cardiac and exercise recommendations. We work with American Medical Society for Sports Medicine, the American College of Cardiology, to update cardiac recommendations, because the literature out there is based on hospitalized patients. We shouldn't need to follow that for asymptomatic carriers. So we give very common sense recommendations there, and I think that'll be helpful to the membership. We updated our sport risk, and we had a lot of conversations about a sport like soccer. Is that a high risk sport or a medium risk sport? I mean, I tend to think it's more medium risk, except after you score a goal in the celebrations, or the amount of time when the soccer players are in the corners. But ultimately, everyone agreed it should be listed as high risk. And then we talk about, well, what should happen to really mitigate risk? And we couldn't get away from the issue of testing. And with regard to high-risk sports, when you're in season, so in season means preseason, regular season, postseason, we recommend that testing needs to be done on a weekly basis. And we went through considerable deliberations about this. It's not the same for medium risk sports. We suggest more of a surveillance strategy, and for low risk sports, we suggest that you do what's done at the university. And then what about for testing? What kind of test should you use? And this is really, really important, because the gold standard is PCR tests. Well, that's fine, except that now in our country, we're moving to a prioritization of PCR tests, because once again, our infrastructure is getting overwhelmed. There's 72-hour waits or more to get test results. You can line up for 8 hours. And can you justify testing asymptomatic college-age students when you're prioritizing testing otherwise? So it's a sad state of affairs to say that we're moving in that direction. But we also talk about point-of-care antigen tests. And we concluded we're not there yet to recommend that as a standard. But one of the important questions we bring up in this document, and this is really interesting, is like, what's more important, to have a very, very high sensitivity test but you don't get the result for 48 or 72 hours? Or to have a lower sensitivity test but you get the result immediately and you can repeat it day after day at a low cost? So that then that sensitivity doesn't matter anymore, because if you're repeating it, the chance of the same person getting a false negative is exponentially lower. So we go through that. We ultimately stay with PCR testing, but I think that's going to shift. And then we say, well, what are the considerations for saying we shouldn't have sport? So if you can't contact trace, if you can't do testing, if your local healthcare infrastructure is overwhelmed and they can't take in any new more COVID cases, and also working very carefully with our local health infrastructure individuals. So we talk about all of that too. So this is a big leap forward for the membership, and it's been really very well vetted. And I think for many, it's going to be sort of the demarcation saying, okay, this is the guidance. We can do it or we can't. And unfortunately, financially, I think it's going to be difficult for some schools to do this.
Okay, thanks for that, Brian. Ron and John, I'll look to you now. As campuses work to develop policies and protocols related to the resocialization of sports, who are the key stakeholders that should be involved in those decision-making processes? Let's start with you, John.
I think that's a great question. I think for us to be successful, we've got to remember that this is not an athletics problem. This is a public health problem. We cannot be siloed. We cannot live in our own little athletic bubble. Other than, obviously, we'll talk about that in a little bit from the bubbling standpoint, but from a global standpoint, we have to know what our university is doing. We have to know what our student health is doing. How are we treating all of our students on campus? And that's the approach that we've taken is tell me what we're doing with all of our students, then we will, add to that from an athletic standpoint. But I think it's so important that you connect with your student health, with your team physicians, with your local, state, agencies. At Emory, we're really fortunate to have emergency preparedness. They're the CPAR. And they make all the critical emergency action planning for our campus. Huge connection. Your hospital. You make that connection of if we are bringing students back on campus and there's a musculoskeletal injury that needs to go to the hospital, is that a COVID surge center? Does that change your emergency action plan? And so I think we could talk about and list, the amount of people that should be a part of it. But I think it needs to go back to think everybody that may have a role in it and you add it to them and have that conversation with them. Because it's got to be a very global conversation.
Ron, your thoughts on that question?
I think John hit the nail on the head. It's bigger than athletics, and you've got to think outside the box and make sure you involve everybody. And even outside the medical community, there's other people involved as well. One group we thought about is facilities are really a key role. Your custodians. We consider custodians and our environmental engineers the first line of defense, and making sure we're communicating with them about infection control and the steps we can take. Another one simple about facilities HVAC. Talking about how can we modify airflow to create negative pressure rooms or increase our air intake from the outside and have more air circulation going through. So I really think it's thinking outside the box and, working as a team, just like in athletics. How many people can we involve to work together to accomplish the goals we want to meet?
Certainly. Ron, I understand that in addition to being a certified athletic trainer, you're also a certified strength and conditioning specialist. So when you're thinking about, as you mentioned, working together and looking through the lens of both of those professions, what will healthcare providers and strength and conditioning staffs need to consider as they work together to transition student athletes back into structured conditioning and athletic activity? And additionally, what should be done to mitigate the potential negative effects of a structured break from conditioning and athletic activity?
That's a great question. I don't know if we've ever had a time like this. This is really unprecedented layoff. When you think about athletes taking 3 to 4 months off for activity and then coming back, and even though you have athletes trying to work out on their own, many times they have very limited facilities, and instead of having a really well-equipped weight room, they've been working with bands at home, or some athletes were filling up a backpack with heavy weights and running around. So it had limited resources. So we have to think outside the box and basically start from scratch. And how can we safely bring them back to a level? And think about not only from a medical standpoint, but also from a musculoskeletal standpoint. And this actually came from the NCAA document about a year and a half ago when Brian came out. They actually asked the Strength and Conditioning Association to come together and form a document for a transition period exactly like this, when you have a long delay, how can we safely bring our athletes back? So what we relied on was the consensus statement that the NSCA and the CSCCA put together with that 4-week transition period and the 50-30-20-10 rule. And that's really a well approached scientific basis for slowly and carefully bringing athletes back.
John, understanding that the staffing resources are markedly different when you compare some D1 programs to those at some D2 and D3 programs. How might athletic trainers and strength and conditioning coaches at D2 and D3 programs work to address this transition into athletics activity? And when you consider the calendar date, start date being adjusted, what will providers need to account for when determining an acclimatization plan?
Let me start off with the calendar. That was the best thing that the NCAA has done with this, in my opinion, from a Division III. I've always said that in Division III, we don't have the time to do the acclimatization like it should be done, especially when you consider that, for instance, our soccer teams will come back and they compete in 10 days. So we've always kind of struggled with that. And so I think the extra calendar days actually gives you the time to do it the right way. And again, I think it's following the acclimatization document that was put out 1.5 years ago. Dr. Hainline, you guys were far foreshadowing potentially of what we're seeing, but that the timing for that document could not have been better. And we likewise we're following that document. I think it's pretty simple when you break it out, and you don't need staff, you don't need athletic trainers, you don't need. As long as you educate your coaches, educate your athletes, your administration on what that should look like, it should not be a staff. What's the word or staff dependent document. Then with that, and that's kind of how we've approached it. The one thing that concerns me the most when we talk about staffing resources is the contingency plans, because we can't think that healthcare workers are not going to get COVID-19. So what does that look like from, that staffing as we bring kids back? And, we potentially, I think at your larger institutions, staff-wise, they can kind of mobilize it and kind of continue the operation. When you're doing with, just 1 or 2 or 3 athletic trainers and 450 student athletes, and potentially you have 2 of your athletic trainers with COVID-19, that may shut down your athletic department quicker than a team would break out. So,
John, continue on that thought of some of the limitations that campuses have. We know that budget limitations are definitely a real concern. With sanitization being a necessary step to reduce the spread of the virus in the athletic spaces, including gyms and athletic training rooms and facilities, what are some non-resource-based strategies and protocols providers might consider? And what personal protective equipment protocols should healthcare providers consider following when interfacing with student athletes?
Education, education, education. Training. That's the biggest. The cleaning guidelines and the PPE guidelines have not changed. I think it was interesting when we were working on the ICDSM document, we were pulling references, and I think the CDC recommendation, it was like 6 years old. And I remember somebody made a comment, well, that's an old document. But the principles of cleaning and sanitizing a healthcare facility has not changed. It's making sure we're doing it correctly. When we spray the cleaning sprays, are we leaving it on the surface long enough to kill? Are we following the directions? Are we using the EPA approved products? So I think that's the biggest thing. Is it's not about increasing your resources; it's doing it correctly. There's a lot of products out, and I've thought about this for our staff, and I think it's a great time for education and educating people how to properly use PPEs. The most dangerous thing for a healthcare worker in COVID-19 is donning and doffing PPEs. So if they're not doing that correctly, you're putting your staff and yourself at risk. So I think that, again, it goes back to training. I can tell you what we're doing at Emory is we want to be able to escalate up to full PPE, but just on a day-to-day basis, we're going to use, for clinical care, we'll use surgical masks, and our athletes will be masked. But again, we've got to remember that, we want to put all this stuff into place where we don't bring in that COVID or potential COVID positive athlete into the athletic training room, but we all know that's going to happen. We're all going to know that they're not going to listen, and they're not going to call you, and they're just going to show up, and all of a sudden you're going to identify that that's a COVID positive case or potential COVID positive case. And I think at that point, you've got to be able to escalate your PPE into, full. We call it full PPE. And I think the same with that would be on the road. Are you traveling with? That's the one thing. If we get to play and we get to travel this year, all of our staff will travel with full PPE just in case.
Great. I'd like to pivot our discussion a bit now to the pre-participation exam. Healthcare providers are reevaluating the pre-participation exam to determine if changes related to COVID-19 are warranted. Schools will have to consider updating protocols not only for incoming freshmen and transfer student athletes, but also for returning student athletes. Ron, what did you and your team physicians consider as you evaluated the pre-participation exam and that process? And did you make any changes to attention that will be given to high-risk student athletes? And also, are you considering including questions related to COVID-19 in your medical exam?
Yes, Gwen. First, we felt it's important that before any athlete went back to activity, because of the time off, that they all had to complete a full PPE. So we mandated that, and we're in the process of doing that with our athletes who have already come back. We did add COVID questionnaires in there, and we actually did a pre-screening the week before they came back. We did a COVID questionnaire as well, identify anything before they came back on campus. The high risk is our biggest concern. So what we try to do is go through our histories and really try to stratify our athletes into low, moderate, or high risk. And the things we looked at specifically were our hypertensive athletes, those in control, those under control, sickle cell trait athletes, diabetes, and asthma. And with our asthma athletes, if they need pulmonary function test, we cleared them to go back. With our diabetic athletes, we actually had to follow up with endocrinologists, get A1Cs to see where they are, and then we're trying to follow them more closely. For example, I have 2 diabetic athletes in football, so before they do any activity, we check the blood glucose and then check again afterward. Same thing with my hypertensive athletes. We check their blood pressure each day before activity afterwards. So we're trying to identify who our high-risk people are and try to hold them to a higher level of monitoring.
Right, thank you. Stephanie, I'd like to turn to you now. Should schools consider including mental health screenings for incoming and returning student athletes prior to participation?
Absolutely. Screening is going to be the key, once again, to identifying which student athletes are at greater risk and higher need for maybe ongoing mental health services or initiated mental health services. One of the things that we've been implementing for all of our student athletes is the Corona Anxiety Scale. It's a 5-item measure, and for all student athletes who've returned to our campus, we have administered that. For our student athletes who are returning, we've also administered, along with the Corona Anxiety Scale, something called the cross-cutting measures, which is a 24-item scale assessment, that asks questions about sleep, appetite, energy, mood, to assess anything that might be problematic based on the last 3 to 4 months that student athletes haven't been on our campuses. So for returners, they will get that protocol, if you will, and for our new student athletes and transfers to our campus, they will get our full-scale pre-participation mental health screening, which is something that we do every year for incoming freshmen and transfers, along with the Corona Anxiety Scale. So this year is unlike other years where we typically just do a full-scale assessment for mental health on returning and new and freshman athletes. This year we're assessing everybody for mental health needs because this is a period in our lifetime where everybody's pretty much at risk for mental health concerns due to physical distancing and inability to, the restrictions associated with socializing and gathering and being in community, along with the loss of seasons and the loss of opportunities and the loss of graduations. And even though some student athletes will be able to come back, there's been a significant amount of loss associated with athletics. And then in the big scheme of things, for everybody in the world, but particularly certain groups, there's been a lot of grief and loss in certain communities who've been disproportionately affected by coronavirus. And we don't know that. They're not all telling us that information, so we have to go get it, because that's certainly going to put them at risk for mental health concerns. So we are absolutely screening all our student athletes as they return.
Understood. And staying on that topic of mental health and well-being, Stephanie, your experience with specializing in anxiety disorders and your work at Walter Reed Military Medical Center around PTSD, it gives you a unique perspective on addressing some of the issues student athletes may be confronted with. When you think of our association-wide campuses and the fact that not all programs have a robust mental health program, what are some things that programs can do to prepare for managing mental and emotional toll student athletes may experience as a result of this pandemic? And if you don't mind, also, if you can speak to issues that's going on in our society now with the social unrest. And you even mentioned earlier, not just how it's impacting our student athletes, but also how it's impacting our healthcare providers.
Okay. For programs or for institutions that do not have a full-scale embedded mental health provider, I would say create if you don't want to create something, you can use the PHQ-9, which is a 9-item depression inventory, or the GAD, generalized anxiety scale, which is a 7-item anxiety measure, and administer that to all your student athletes, because that will give you some information about, and those scales have cutoff points where somebody would be considered with an anxiety disorder or at risk for anxiety disorder, or somebody who's not having any anxiety concerns. If you would like to be more specific, I encourage you to create your own. You can just ask the questions. You can ask questions about sleep, because one of the things that we know is that when people are starting to struggle with mental health, sleep is one of the things that is generally impacted first. So you can ask questions about sleep. How much sleep are you getting on a nightly basis? Appetite, energy, mood, and that issue about grief and loss. Because as I mentioned, even if you haven't lost a relative or somebody you know, there's just been a significant amount of loss of freedom, loss of livelihoods, loss of just so much loss in the past 6 months, 4 to 5 months, that it's very hard for any of us in our community to not have been impacted by that. I've lost the ability to go to work in my office for the past 5 months, and that's a loss. And to communicate and congregate with my colleagues and student athletes. So we're all facing these losses. So I would really encourage folks to just ask the questions. If you don't want to use something that's standardized because it's not exactly getting at what you like, create something. When I came into my role at Temple, I created documents and assessments based on the information I wanted to gather. This is a great opportunity for us now to create documents based on the information, because we all have different circumstances depending on where we are in the country. So what might work in Georgia may not exactly work in Philadelphia, or may not work on the West Coast. So this is a great opportunity for us to create. But then, once again, there's a lot of things out there. Corona Anxiety Scale, 5 items, easy to give or administer, PHQ-9, GAD, and some of the other inventories that are there. As it pertains to my work working with soldiers and post-traumatic stress disorder, once again, at a very root level, we've all been we've all experienced some trauma in the last few months. And for many of us and many communities, that has been doubled. So when we talk about some of the racial unrest that we've been all witness to in this country, that trauma associated with repeated observations of murders and violence in terms of protests. Many of the protests have been peaceful, but there have been some violent protests. And so like all these things have been traumatizing to already group of people who are already facing trauma. So we need to take all of that into consideration. There are particular groups of student athletes who are we need to have our eyes on. So our student athletes of color, Black, Hispanic, Asian Americans, indigenous populations, these are student athletes we really need to assess for things like trauma and mood disorders because of some of the experiences that we've had in the past few months.
Thank you. Brian, as you know, the NCAA conducted a well-being survey for student athletes earlier this summer. There were responses from more than 37,000 student athletes. What have we learned from the recent NCAA student athlete COVID-19 well-being survey? And considering what the student athletes reported in that survey, are there specific NCAA resources available to address the needs of the student athletes?
The survey went out to about 38,000 student athletes, and just a couple of really highlighted points. One is that if we look at all student athletes and compare them where they are now to where they were pre-COVID, depression, anxiety, and other mental health symptoms and we suspect disorders are markedly higher than at baseline. And then in particular, student athletes of color, and those international student athletes and those who had really economic hardship at home, they in particular had marked mental health symptoms and disorders, especially depression and anxiety. So that was one thing. And with that, on the nca.org/SSI page, there are a lot of mental health resources, and we sent that out to the membership. But we took it one step further. This is something we had been planning for some time, and then with the survey, it really revved up our plans. So with Dr. Coakley actually and with Daryl Conway from University of Michigan, they're going to be co-chairs of a mental health task force that's going to be taking place August 10th and 11th. And it's specifically on cultural sensitivity issues and in particular really addressing student athletes of color. And so we've known for some time, if you look at especially some football and basketball powerhouse schools, there's an overrepresentation of Black athletes and you know, from the coaches and athletic directors' point of view, an overrepresentation of white men. And so that sets up a potential conflict where there's a cultural sensitivity breakdown. But even further, when you look at the literature out there, we've actually have completed a narrative review of the literature, and it's just not great when it comes to addressing cultural sensitivity issues, especially for our athletes of color. So we're going to have a task force, and it's going to have short-term and intermediate-term and long-term goals in mind. So short-term, we're actually looking at the survey and the narrative review of the literature. We're going to come out with foundational statements. The intermediate plan is that we're going to use those foundational statements for actually doing a deeper dive survey and to get educational and policy resources out there. And then long term, it's really interesting. I mean, you look at the medical profession. So there were more Black male individuals and Black men in medical school in the 1970s than there are today. In licensed mental health care, there's a vast overrepresentation of white licensed mental health providers. Athletic training, same thing. Coaches, same thing. So long term, we had this project called Athletes in Medicine and Science, and we were actually supposed to begin it this year as a pathway for athletes of color into medical school. And that's going to be enlarged really to also have a pathway for licensed mental health care, athletic training, coaching. So it's great. I'm just going to sit back and watch this happen as Stephanie and Daryl kind of like lead the way and take us through where we need to go. But the survey was, it wasn't a wake up call, but it was sort of like in your face. Look, this really exists, and it served as a real impetus to move forward more precipitously with this task force.
Thanks for that, Brian. Ron, shifting our discussion to independent medical care, I'd like to turn to you now. Independent medical care legislation passed in 2016, giving primary athletics healthcare providers the unchallengeable authority for medical decision making. How are the provisions of independent medical care legislation applicable as programs work to bring athletes back to campus for practice? And additionally, you serve in the role of the athletics healthcare administrator on your campus, and I'm sure you understand firsthand how instrumental the AHCA role is to the support of independent medical care on campuses. What should the athletics healthcare administrator be doing during this time as well?
When we passed the Independent Medical Care 2016, I think that may have been the most profound and important legislation NCAA has ever passed. And again, it's about athlete health and safety, and that's our first and foremost guidance. So I think, first of all, we need to really focus on that. This is a health and safety issue above all. So making sure that when we plan our PPEs, that we're doing it the right way, particularly the transition, that we're making sure it's safely done and medically done. So, for example, our institution, we made some guidelines that max fitness testing couldn't be done for a certain period to allow the athletes to acclimate back at an appropriate pace. From the role of the healthcare administrator, I really think they're the point person. This is a medical issue, and I think medical needs to be involved in all decisions. And it was interesting. I was really pleased with the way this developed from a campus standpoint. I can honestly say every committee that we had, medical was involved for return to work, for return to sport, and making sure it was done in a safe way. And really, the AHCA is the point person for the community as well. For example, Brian said it really well. This is a public health issue. And although in our world, athletics is really important, we need to make sure that we're working together with the community. For example, testing is important for us, but I've got to make sure that our testing program doesn't adversely impact the public health for our community. So making sure that we're working with our local providers or the hospitals, making sure that we're coordinating everything together, and we want to work together to have the best benefit for everyone.
Great, thanks, Ron. We only have a few minutes remaining in our session, and I did want to get to a question related to staffing. John, I think you are aware of the reports of staff positions in athletics departments being eliminated, or campuses imposing hiring freeze in instances where staffers are being furloughed. What have you heard about the impact of the current situation on athletic trainer and team physician staffing, and what impact might these issues related to staffing have on plans as student athletes are returning to campus?
Yeah, I've heard multiple situations. I think even not at the college level, but even at the high school level, where getting rid of athletic trainers. Because that's an easy way to cut costs. I know many of my colleagues have been furloughed, and it's not all at the Division III or Division II level. I mean, there's some Power 5 athletic trainers who've been furloughed. For me, it's a big concern in the fact I know how busy I've been since March. Typically at Emory in Division III, the end of May, we're done with our final championship. All of our kids go home. They go and they do internships in New York, and there's a few that stay up, but we don't have programming all year long. So a lot of times for me and my staff, it's a time for a break. The amount of time I've put into the COVID planning and Zoom calls and thinking about this topic, I really worry about the institutions out there that have furloughed their staff, their athletic training staff, and who is making these decisions or who is guiding in these decisions. And I think that's a really, really big concern. I think, obviously, at the end of the day, it's economics, but at the same time, we've got to protect these student athletes and who the person that's looking after them, we get rid of them or we furlough. That's really scary to me.
Thanks, Sean. In the last few minutes that we have, Brian, I'm going to give the last question to you. It's hard to consider that we haven't yet begun our competitive season, but I know that plans are being contemplated regarding the culmination of the competitive season. What steps will NCAA implement to minimize risk of coronavirus exposure to participants, officials, and spectators during future championships?
In season, LeGwen, with the newest recommendations, a lot of times people use tier 1, tier 2, tier 3. We use the concept of inner bubble and outer bubble and intermediate bubble. So the inner bubble are really the athletes and all those who have a close or intimate contact with those athletes. That includes officials on game day. And so for the regular season, as for the high risk sports in all divisions, I mean, there needs to be testing of all of the inner bubble individuals before the competition. So that's one thing. Seems like a small issue, but it's actually a pretty kind of interesting issue. Officials shouldn't be using regular whistles anymore. They should be using electronic whistles. Everyone should be masked. And so, you think about what that means on a sideline. There's no one on a sideline without a mask. So it's great that the coach is wearing a mask, right? But if a player is coming off the field on a 30-second timeout and has to talk to the coach, that player has to be masked. So we talk about all of those issues, and that's logistic. For the championships, we've had considerable discussions about championships. So the championships, those are under the national championships, other than the college football player. That's under NCAA control. And you think about the logistics of that. There are over 400 sites alone for the fall championships, most of them non-predetermined. So that's a logistical nightmare, and that can't exist in the era of COVID. So we're going to be decreasing the number of sites. They'll all be predetermined. It's sort of, it's unfortunate for some schools because, you have a great win and all of a sudden you get to host a championship and you only have 1 or 2 days to put it together. That doesn't make sense in the planning for COVID. And then we're actually putting out an RFP very soon for really a comprehensive testing strategy for our championships, not only for the fall, but going beyond that, because COVID is going to be here for beyond the fall season. So that's the essence of what we're doing. And again, it's always, I think John was spot on when he said, look, this isn't an athletics issue. This is a global public health issue. And so we're all part of that. But then we take this one part of athletics and, when you think about it, I think athletics and even playing a game, you're probably at less risk than when you're hanging out in the dorm or going to a party. And we have to recognize that. And so, but this is a chance for sport to step up and I think we can actually provide leadership that's going to help the rest of America open up because they're looking to us. And so it's important that we get it right.
Great. Thanks, Brian. I said that I was giving you the last question. I am going to throw a little curveball and go to Ron. Ron, when you're thinking about these parameters and you being in the trenches on campus, how do you see this playing out on your campus with your student athletes?
Well, I think we have to look at it as a new normal. As Brian, when he described the bubble, when essential personnel, who needs to be in that bubble? And I think what you'll see, like from a practice standpoint, is going to be radically different than we have in the past because athletics has always been so open. If you think about practice on a daily basis, who has typically been there? You might have a number of NFL scouts, and you might have media, you might have guests and boosters and other people. So we have to think of it from a now standpoint, who is truly essential, who do we need to really operate their practice, and who can we cut from that standpoint. So what we're really trying to do is really sort of dial down to truly essential people and only have those people on there, and that's less exposure for our student athletes.
Great. Wonderful. That brings us to the end of our discussion. Let me close by giving a very special thanks to our panel members, Dr. Stephanie Coakley, Ron Corson, John Dunham, and Dr. Brian Hainline. I'd also like to thank the viewers for your time. We wish you well as you prepare for the start of the academic year and the upcoming fall season. Thank you.